happy to have this opportunity to bring your attention to a study that FHI 360 conducted in collaboration with the Women's Health Research Unit at University of Cape Town. The study tested an intervention for expanding contraceptive options for postpartum PMTCT clients through the promotion of long-acting and permanent methods. And so in South Africa, at the time of the study, that implied female sterilization and the IUD, in addition to the rest of the methods that are available in South Africa. And the idea for this study arose from prior formative research conducted with PMTCT clients that showed a high proportion of them reported that their previous pregnancy had been unintended and they desired no future pregnancies. So this was a simple descriptive study, pre- and post-intervention cross-sectional surveys conducted with postpartum PMTCT clients who were intercepted at child health services. Typically, they were bringing their newborns in for immunization. So after conducting the pre-intervention survey, we introduced a multi-component intervention. We trained NCH providers on the importance of family planning in PMTCT. We also shared information on the contraceptive methods that are safe and effective for women living with HIV. We offered clinical training on IUD removal and insertion and removal. We worked with facilities in ensuring they had the necessary supplies and equipment, especially for IUD insertion. We made available existing INC materials, such as a pamphlet that outlines all the contraceptive methods available in South Africa. The study employed a consultant who served as a coach. She visited the study facilities, there were 5 in the greater metropolitan area of Cape Town. She visited them once or twice a month to reinforce what they had been taught in training and encourage providers to promote the full range of contraceptive options. And then we also worked with strengthening the mechanism for referring clients from public sector health centers to the NGO that provides female sterilization in the area. So in addition to our pre- and post-intervention survey, toward the end of the study, we did in-depth interviews with 16 providers who were exposed to the intervention. And throughout the whole process of implementing the intervention, we carefully documented the components using a tool that FHI 360 calls the intervention tracking tool. Now, through our surveys, we looked at knowledge, attitudes, and behaviors related to contraceptive use among postpartum PMTCT clients. Our main study outcome was the proportion of respondents who knew that the IUD and female sterilization in general was safe and effective for women living with HIV, and they knew where to get those services. So this slide presents some of the findings, and in the interest of time, I'm going to have to just sum it up. This is knowledge about the IUD and female sterilization being safe for women living with HIV, and the results are on the poster in the next room. I'd encourage you to take a look if you're interested. But I can sum it up for you by saying that there was no improvement between pre- and post-intervention in knowledge about the IUD, and there were just modest improvements about female sterilization. So when we take all the study data together, regrettably, the study team concluded that the intervention was not effective in promoting uptake of long-acting and permanent methods among PMTCT clients. Nonetheless, when we looked at the data from the in-depth interviews with the providers and the intervention tracking, we learned a lot. And there were 2 important lessons. One is that before interventions are introduced, we really need to focus attention on the health system's components undergirding service delivery, especially workforce human resource management, also commodity management, and what we call governance, the transfer of policies all the way down to the district and the health center level to make sure policies are translated into practice. And the second and final lesson is the importance of documenting the implementation of interventions. As we introduce integration interventions and scale them up, it's very important that we document them so that we know the extent to which they're implemented as intended, and we can continue to learn about the health systems components that need reinforcement for integration to succeed.
Thanks very much. That was good and in the 5-minute slot. And now, unless John IH has arrived, I will now move on to invite Janet Masini to present her poster.
Good evening. I'm going to share with you a project that we are running in the Kilifi district that is looking at provision of integrated sexual and reproductive health services to female sex workers through the method of using a drop-in service center. ICRH Kenya, with the support of UNFPA, we are implementing a project that is aimed at addressing the sexual and reproductive health needs and promoting behavior change among female sex workers in Kilifi. And it's based on this that one of the strategies we looked at is how can we have integration of services for them that are user-friendly, and we established 2 drop-in centers. One was in Chwapa and another one was in Kilifi town. And these centers provide sexual and reproductive health services to female sex workers. They're able to access these services for free, and from that we're able to make referrals to the Ministry of Health to services that are not available at the center. And in the centers, the female sex workers, together with their clients and their peers, they're able to come through mobilization work and referrals by peer educators. We have a set of 70 peer educators who are female sex workers that were recruited and trained in peer education, and we use them to be able to mobilize their fellow peers and also to bring their clients to the centers to be able to access the services. The services that we provide are HIV testing and counseling. We have screening and treatment for STIs. We have screening for cervical cancer using the VRBD method. We have provision of family planning methods, counseling for alcohol and drug reduction, because this is something that we know that female sex workers have. They do abuse alcohol and drugs a lot. We have the distribution of male and female condoms and lubricants, counseling and referral for gender-based violence, because they also experience a lot of sexual and gender-based violence. And then there's the distribution of IC materials and referrals for other services. Just to give you an idea of what happened is that services like cervical cancer screening were not carried out in 2011. And one of the findings that we found from this was that they usually used to come to the site and they usually kept asking for this service. And we realized that we needed to have a drop-in center that would be a one-stop for them, where they're able to receive all the services that they need. And what happens is that we work with the Ministry of Health. They provide for us the nurses and the clinical officers to provide these services. And by doing this, we have a linkage to the Ministry of Health, whereby if they come to the drop-in center and they do not get the service that they need, they're able to go to the nearest Ministry of Health and get the healthcare provider, who they also are able to get at the drop-in center. And through this, they're able to access the services. So we have found that drop-in centers are user-friendly for female sex workers. Other maps, in this case we're talking about MSN and MSWs, because they are also using the drop-in centers that we have and their clients. And they're able to access all these services in one place. And we recommend this as a model of integration for any services or any project that is dealing with that. And also that they are a linkage to the Ministry of Health facilities. And this, therefore, in the process ensures sustainability of the services offered. Thank you.
Thanks very much. Now let's move on to Jacqueline.
Good evening, everyone. I would like to talk about a project that we're implementing with support from AFEPLUS, and we work very closely with the Ministry of Health. And this is based on a formative study that was carried out in 2002. that highlighted some of the barriers that MSMs have towards seeking health services in the health facilities that exist. So the commonest of all was that most of the MSMs do not seek health services because of fear of being stigmatized. And therefore the method that we use is basically drop-in centers that are MSM friendly, and we have two established, one in South Coast, Kunda, and another in Mombasa, CBD. And at the center, we have trained MSM educators who participate in in-reach activities, basically involving in-reach activities that basically involve mobilizing other MSMs to come and seek services at the drop-in center. And they also have health education days, which are aimed at educating their peers on HIV and STI prevention. And they are also referred for other services to the MOH facilities for services that do not exist at the drop-in center. And at the drop-in centers, both drop-in centers offer services such as HIV testing and counseling, STI screening and treatment, family planning services, condom and lubricant promotion and distribution, and like I said, referral for health services that do not exist at the drop-in centers. And these are just key findings for the year 2011 for the services that are provided at the two drop-in centers. You can see HIV testing and counseling, clients totaling 4,513, STI screening and treatment, clients totaling to 1,221, and we do promote a lot of condoms and lubricants in these drop-in centers, and then MSMs are actually able to access the condoms and lubricants at the drop-in centers. Though I have to acknowledge that the water-based lubricants are quite a challenge to get lubricants because they are quite costly, and but they do access them at the drop-in centers, as highlighted in this finding. And in conclusion, what I would say is that increased access to health services for MSMs and their clients is best achieved using innovative methods such as integrated services provision through the MSM-friendly drop-in center. And the drop-in centers provide a safe space for the MSMs to discuss their personal issues and also educate themselves on various ways of preventing HIV amongst other STIs. And being involved in this discussion at the drop-in center also enables them to access these services and therefore enhancing uptake of these services. And involving MSMs in service provision to their peers and clients also gives credibility to these drop-in centers and therefore improving uptake of the services. And we do involve the Ministry of Health a lot in our projects, and therefore to promote the sustainability, we encourage that we can be able to have MSM-friendly services provided at most of the MOH facilities, because the complaint that we have from the MSM is that they fear being stigmatized, and they feel that the services provided at most of the MOH facilities are not sensitive towards their productive needs. Thank you.
Thank you very much, Dr. Now our students to come up.
Good evening, everyone. Yeah, I'm going to present to you findings from a project that was implemented in Zambia and was trying to improve the quality of care for postpartum or postnatal care for women and their babies. And the project came about because there were gaps in terms of the provision of postnatal services for women and their babies. The gaps were mainly on linkages to other services such as FP or family planning and HIV, as well as the quality. There are also issues of quality and content. So as a result, the Ministry of Community Development, Mother and Child Health, and Population Council with support from WHO, they developed a intervention that was trying to strengthen the provision of postnatal care services to women and their babies. So the intervention was a pre and post, before and after intervention, whereby the facilities were clustered in the districts, in the two provinces of southern and eastern in Zambia. And the two districts in each of these provinces, Chipata, Choma, Livingstone, and Lundazi. And what we are trying to do was to compare this strengthened package of postnatal care with the standard care. The standard care only had services for immunization, close monitoring, child welfare, and family planning at 6 weeks postpartum. While the strengthened one had a few more services such as cervical cancer screening at 6 weeks, infant feeding counseling. There was also examinations for the mother and the baby to detect any danger signs of complications, as well as HIV testing, prophylaxis, and referral and follow-up system. So the analysis we focused on data that was collected from provider interviews. This was a total of 158 at 24 facilities. This was part of the data that was collected from the health assessment that were conducted to assess the intervention. So we conducted, or we performed descriptive statistics to look at the associations between key outcomes and vis-a-vis the group membership. We also conducted difference in differences analysis so that we see whether the change between baseline and endline was a result of the intervention activities. And the intervention activities were focused on 8 areas. One of the areas was to improve the provider capacity to provide for postnatal care. And this was to build their skills and knowledge on how to give integrated, comprehensive postnatal care as well as postpartum family planning and HIV services. So coming to the results, be very, very brief. If you want more details, we have a poster outside, but you can also talk to me. I'm focusing on 2 key areas, that is the provider knowledge and whether we know core aspects of PNC, as well as the training. And looking at the results, we can see that at endline, there was relatively higher knowledge in terms of what PNC constitutes. That was at 80%, although this was a drop based on the baseline figures that was at 91%. Looking at endline, we find that intervention facilities, very few providers knew that postnatal care period is care for the mother and baby until 6 weeks following birth. So you see the comparison sites are doing much better. To conclude that particular section for provider knowledge, we found that the knowledge among the providers on core aspects of PNC was still poor. But the encouraging news is that the intervention activities improve knowledge on danger signs and preventive care for newborn. Because for knowledge, we had about 8 items to assess the providers on. Secondly, we were also looking at the training. Before the intervention, we found that most providers were trained on provision of HIV services. Training on cervical cancer screening, integrated management of childhood illnesses and adult illnesses was very minimal because the scores, we had to take mean scores on areas that the providers had been trained on. So we found that mean scores were very low for those areas. At endline, we found that providers had been trained on provision of comprehensive PNC services. We saw that there was an increase in areas pertaining to the provision of integrated comprehensive PNC services. But overall, we can say that there was a positive effect on providers' training on FP and PNC issues, particularly integrating counseling and testing for HIV into PNC and integrating counseling and testing for HIV into FP. My part in short is that the model has the potential of improving provision of training and provider training and provision of PNC services. However, we encountered a lot of challenges, system challenges, such as staff shortages that really affected the implementation of the project. Because you find that you train healthcare workers, when you go back you find that maybe they've been transferred or they've gone to another site, because we utilize the mentorship approach, whereby we train a few providers and then they go back to their facilities or workstations and train their colleagues. But you find that the one you train, but probably they are transferred or they've gone away. So that kind of affected the implementation of the project. And that's my end of my presentation, and those are the acknowledgements. And thank you.
Thanks very much, James. So now I would like Will Pista to come.
Good afternoon. Michael. Thank you for reminding me, and keep on reminding me if I forget anything. Good afternoon. I present findings of a study that was done by ICRH, that is my organization, together with the Population Council in Mombasa. Now the study was done 2010, the year 2010-2011, targeting people who are HIV positive, living in the community. No one knows what they did or what they were doing there, but they were not on any care. Now this study was informed by a survey done in 2007, dealing with Council, that established that these people are there, they are in the community. I am going to tell you more about them. Now this study asked a question. If these people are in the community, how do we reach them in that community? And who are we able to involve to reach them? So we conducted a study that was a two-arm intervention control. It was a prospective cohort study, as I mentioned, done in 2010-2011, with a pre-intervention that is baseline and a post-intervention that is end-line measures. Now we wanted to assess the effectiveness of a risk reduction prevention strategy delivered by community health workers for HIV positive persons who are just living there in the community, but they are not on care. Now, as I mentioned, this study was informed by a survey done in 2007. Now, this survey actually established that nearly 60% of HIV positive people who are not on ART are sexually active, but they are also having multiple partners. There's a lot of details about this. The poster is out there with the same labeling, prevention with positives. How do we reach them? So I'll just give you a very brief of what is there, but after that, I will give you all the time to discuss the poster out there. So for this study, community health workers help to recruit HIV naive positive persons from the community. These are people who are treatment naive, actually. They are HIV positive, but they are not on any treatment. Or they also help recruit people who have stopped taking ARVs for the last 6 months. So they started but stopped. So they are just there. I have said they are sexually active. They have multiple partners. They do anything that all of us would do. So after a total of 634 people living with HIV were recruited in the study. And out of that, 606 were interviewed at both baseline and endline. So the people who completed both baseline and endline were 315 in the intervention wing and 291 in the control sites. Now the people in the intervention sites that I'm talking about were followed 4 to 6 times with one-in-one education sessions on PWP messages. Community health workers who enrolled them reached them on one-on-one with lessons about condom use, about the importance of taking ARVs, about partner disclosure, about HIV testing for themselves and their family, and all that. And during this study, we only collected quantitative data. I presented the results. Now, after the intervention that I've said was only 6 months, and I also beg to mention that in the control site, we allowed participants to access the health services that they have been accessing, but our community health workers did not reach out to them with any interventions. But in the intervention site, they were reached with one-on-one sessions, at least 4 to 6 times, within a span of 6 months, before we called them back to interview them for airline. Now these are the results. The mean number of sexual partners decreased in a span of 6 months. People say, if I had 2.78, and these people have told me something that makes sense to me, let me reduce. So in the intervention sites, where we had 315 people completing baseline and endline, the mean number of sexual partners in the past 3 months decreased from 2.78 to 1.5. There is a little decrease at the control from 1.9 to 1.6. Now, looking at the partners still, now the percentage of people, participants who had one partner also increased tremendously in the intervention site from 55% to 78%. And on the reverse, people who had 2 or more partners also said, let me reduce. So there's a reduction from 44% at baseline to 20.7. So so people became very selective, saying, let me get space. Only have people who make sense to me, the rest let them go. Consistent condom use with the most recent partner increased from 30% at baseline to 86% at endline because of intervention. And to add, ARV intake also increased from 0.8 to a significant 35.2%, and that is in only a span of 6 months. Now, disclosure of HIV status to the male sexual partner. Of course, we could be well aware that HIV status is difficult to disclose. So after the intervention, people said, okay, let me disclose my status. So disclosure rose from 52% at baseline to 83% at endline. A lot of details about this at the poster. Please don't miss this. Now, I want to conclude that based on the results of this study, community health worker delivered intervention actually increase HIV-related knowledge, disclosure, condom use, and plus. And HIV prevention programs can use community health workers to expand the reach of HIV prevention services in our communities. And the role of community health worker, we underscore, is very important. And they become very important when you train them, when you support them, and when you give incentives. I would want to close by saying that we are talking about integration. It is like a cocktail of a shop with sabuni and oil and all that. But we need to ask ourselves, where are the buyers? And how do you arrive at the buyers? Otherwise, you can have a full-blown shop and no one comes there. Thank you for your attention.